Hello, everyone. Welcome to week one of our introduction to psychedelic assisted psychotherapy. In week one, we cover two readings. So, what I want to emphasize is this week is not about technique or clinical protocol, but really wanting to give you a foundation for this field, for different schools of thought. And so I want to emphasize that psychedelic assisted psychotherapy cannot be reasonably or responsibly practiced without understanding the historical, ethical, cultural, and political conditions from which it emerges. So we'll be covering this in more detail throughout this semester. But my lecture this week is structured explicitly around two very different ways of knowing psychedelics. So, Dennis McKenna, the chapter that we read, he offers a critical ethno botanical and relational lens, while Rife and his colleagues represent a contemporary biomedical and psychiatric synthesis of a few substances that are used in assisted therapy. So, what I want to do here is hold tension between these perspectives and recognize that that's not a problem to be solved, but it's a skill that you'll develop throughout this semester is holding tension between differing perspectives. So, I want to start this lecture and this course by emphasizing that this course is going to resist reductionism. So, psychedelic assisted psychotherapy will be treated as a complex relational practice, not simply a drug based intervention. Okay, so for this week, I want you just looking at learning objectives. These emphasize critical analysis rather than clinical technique. At this early point in the course, you're not expected to know how to conduct psychedelic assisted psychotherapy, but you should begin developing a sophisticated understanding of how this field has emerged, whose knowledge has been privileged, and what ethical responsibilities accompany clinical work in this area. So, when I say situate historically and culturally, I'm naming that psychedelic use long predates Western psychiatry and that criminalization is a relatively recent political event. The second objective explicitly introduces epistemological tension. So, indigenous and shamanic traditions prioritize relationality, ritual, and community accountability, whereas biomedicine prioritizes standardization, diagnosis, and replicability. Critical evaluation of the psychiatric evidence base does not mean rejecting science, but learning how to read research carefully. You're looking at things like sample sizes, methodologies, power dynamics, and claims being made about the intervention. So, finally, ethical implications are not an add on, they are central to clinical identity, especially given histories of colonialism, exclusion, and inequitable access to care. All right, so starting with the McKenna chapter, the plants for the people, the future of psychedelic therapies in the age of biomedicine. So McKenna is not writing as a clinician offering a treatment manual, but as an ethnopharmacologist and cultural critic. His goal is to challenge dominant biomedical narratives and to remind you, the reader, that psychedelic substances have long existed within relational, spiritual, and ecological systems of meaning. So McKenna is an ethnopharmacologist rather than a clinician, as I said. This matters because his goals are not to outline a treatment manual, but to interrogate how psychedelics are being reabsorbed into Western systems of power. McKenna is concerned with meaning, relationships, and ecology. His chapter is fundamentally a critique of how biomedicine risks flattening psychedelics into commodities. So I want to invite you to read this chapter not for how-to guidance, but for its ethical provocations and historical consciousness. So, a central thesis, its core argument is that psychedelic plants should be understood as co-evolutionary partners rather than pharmacological interventions. From this perspective, healing does not reside in the molecule, but in the relationship between humans, plants, culture, ritual, and ecology. This challenges Western medical models that attempt to isolate active compounds while stripping away cultural and spiritual context. When McKenna says psychedelic plants are not inventions, he is resisting the biomedical impulse to claim discovery and ownership. These plants existed long before Western science took interest. One thing that I do want to emphasize for all of you, and I will point this out when I get into the Rife article, um, is that many of the substances used in assisted therapy, and I'm not saying psychedelic assisted therapy, because not all of the substances that we'll be talking about this semester are psychedelics. Actually, the only one that's considered a psychedelic, a classic psychedelic, is psilocybin. MDMA is not a psychedelic. Ketamine is not a psychedelic. So, in regard to talking about these substances as plants, also, MDMA is not a plant. Ketamine is not a plant. The plants that we'll be talking about this semester are psilocybin, ayahuasca, peyote, ibogaine, but none of the other substances that we'll be talking about are plants. So I just want to be clear when it comes to language in this class. Okay, so coevolution suggests a reciprocal relationship. Humans and plants have shaped one another culturally, biologically, and spiritually. And then this final piece here about psychedelics function within relationships is crucial for you, students. Healing does not occur through protocols alone. Instead, psychedelics function within networks of relationships that include the user, the guide, the community, the cosmology, and the environment. So, this idea will reappear later when we discuss setting, and therapeutic alliance. All right, so indigenous and shamanic traditions. So McKenna situates psychedelic use within indigenous and shamanic traditions that predate Western psychiatry by centuries. In these contexts, psychedelics are embedded within ritual, cosmology, and community accountability. Healing is not individualized symptom reduction, but a process involving spiritual insight, relational repair, and communal meaning making. Again, indigenous psychedelic use is not recreational or individualistic. Ceremonial use is embedded in spiritual cosmologies that give meaning to altered states. Healers are not interchangeable technicians. They are cultural specialists trained through lineage, apprenticeship, and communal accountability. Healing in these contexts is relational and collective. Suffering is understood as disruption within a social or spiritual field, not merely an individual pathology. So I want to invite you to consider how radically different this is from Western diagnostic frameworks. So long before contemporary researchers operationalized the concept of set and setting, indigenous traditions recognize that mindset, environment, ritual structure, and social context fundamentally shape psychedelic experiences. McKenna argues that meaning and intention are not secondary variables, but primary determinants of therapeutic outcome. Ritual functions as a psychological container that provides safety, expectation, and coherence. So, yeah, ritual function, sorry. So, community and cosmology shape how experiences are interpreted. Visions are not random, but culturally legible. The phrase meaning precedes mechanism is key. McKenna argues that understanding what an experience means to a person may be important rather than identifying its neurochemical pathway. This directly challenges reductionist neuroscience and prepares you to think relationally about therapeutic change. All right, so colonialism and knowledge extraction. So McKenna raises explicit concerns about the ways Western societies have historically extracted indigenous knowledge without reciprocity. This includes the commercialization of sacred plants, the rise of psychedelic tourism, and the reframing of indigenous practices through Western scientific lenses that often erase cultural origins. So, here we'll explicitly name colonial dynamics. Western researchers often extract substances and knowledge without reciprocity or acknowledgement. Spiritual tourism, particularly around ayahuasca, raises ethical concerns about exploitation, environmental degradation, and cultural erasure. So I encourage you to reflect on how clinical legitimacy is often granted only when Indigenous practices are reframed through Western science. This is meant to invite a little bit of moral discomfort, which at this point is appropriate and very intentional. So, as psychedelics entered Western scientific inquiry, they were reframed through biomedical paradigms that prioritize standardization, replicability, and risk management. McKenna does not reject science outright, but warns that biomedical reductionism risks stripping psychedelics of the very contexts that give them meaning and therapeutic power. So McKenna is not anti science. He acknowledges the importance of safety, dosing control, and empirical rigor. However, isolating compounds can also isolate them from the relational contexts that shape their effects. Here's the trade off: increased legitimacy and safety may come at the cost of meaning, ritual, and community accountability. This tension will appear throughout the course. And when I originally, like the first time that I taught this class a couple summers ago over this for the 10-week course, I actually began the course talking about shamanism, the ritual and just traditional history of compounds of what would be considered plant medicine, because that's what indigenous people use is plants. Um, and we'll get to that. So you'll learn about, talking about here with the relational context that shape their effects, and the cultural meaning. We will get to that toward the end of the semester. So if you're curious, we will talk about shamanism, animism, all that fun stuff that comes with just the cultural roots of and indigenous roots of plant medicines. All right, so here I want to connect ethics to systems of power. Corporatization risks turning psychedelic medicines into luxury interventions accessible only to the privileged. Patents raise questions about ownership of substances derived from ancient practices. I'm asking you to consider: who is included in the psychedelic renaissance, who will benefit from psychedelic therapies, and who is excluded. So these questions are especially relevant for clinicians committed to equity and social justice, as they centralize access, profit, and power. So McKenna cautions that the current psychedelic renaissance may reproduce colonial and extractive dynamics if ethical considerations are not foregrounded. All right, so a very different perspective here coming from Reef and colleagues. So they represent a mainstream psychiatric synthesis of psychedelic assisted psychotherapy. So this article is grounded in evidence-based medicine and focuses on clinical trials, safety, and therapeutic outcomes. This article is cautious, evidence-based, and written for a medical audience. So this is the voice policymakers, insurers, and regulatory bodies are most likely to trust. So rather than framing this as better or worse than McKenna's perspective, I want it to be framed as a different epistemological position with different priorities. Okay, so Reif and his colleagues define psychedelic assisted psychotherapy as a structured, multi-phase clinical process. Importantly, the psychedelic substance is embedded within a psychotherapeutic framework. Preparation and integration are not optional adjuncts, but essential components of care. So the preparation involves psychological screening, intention setting, and therapeutic alliance building. The medication sessions are highly structured and safety oriented. Integration sessions are where meaning is made and incorporated into daily life. So I want to stress that Reif and his colleagues insist that therapy is not optional. Without preparation and integration, outcomes are poorer and risks increase. Okay, so like I said before, um, it's important to understand the different substances because it's not appropriate or accurate to call all of these psychedelics because they're not. It's also not accurate or appropriate to call all of these plant medicines because they're not. So, for example, um, like instead of calling MDMA psychedelic assisted therapy, you call it MDMA assisted therapy. You would say LSD assisted therapy, for example. So just giving you some language here. So Rife and his colleagues review multiple psychedelic substances or just multiple substances, each with distinct pharmacological profiles and cultural histories. While psilocybin and MDMA dominate contemporary research, LSD and ayahuasca are also discussed, albeit with more limited and heterogeneous data. So the authors are not discussing psychedelics as a single homogeneous category. Instead, they review specific substances, each with distinct pharmacological properties, like I said, cultural histories, and research trajectories. So starting with psilocybin, Reef and his colleagues note that it is currently the most widely studied classic psychedelic in modern clinical research. This is not because it is necessarily superior, but because it is relatively short acting. It has a favorable safety profile and is easier to standardize for clinical trials. Its prominence already reflects how regulatory feasibility shapes scientific knowledge. MDMA is included even though it's not a classic psychedelic. Rife and his colleagues justify its inclusion because MDMA is central to the contemporary psychedelic assisted psychotherapy movement, particularly for PTSD. MDMA's effects on fear processing, trust, and emotional openness make it especially relevant for relational psychotherapy, which is why it accompanies such a central role, or sorry, why it occupies such a central role in current clinical discourse. LSD is discussed largely in historical terms. Rife and his colleagues acknowledge its foundational role in early psychiatric research while also noting the scarcity of modern trials due to regulatory barriers, long duration of action, and political stigma. This highlights how legal history constrains what counts as current evidence. And then finally, ayahuasca is treated with notable caution. Rife and his colleagues recognize promising observational data, but emphasize heterogeneity in preparation, context, and ceremony. This substance most clearly exposes the limits of Western clinical research methods because ayahuasca is inseparable from indigenous cosmologies, ritual structures, and communal meaning making. So we can tie this back to McKenna's article about noticing how the substances most easily abstracted from indigenous contexts are the ones most easily medicalized. Right. So this article highlights clinical populations that are often treatment resistant to conventional interventions, essentially just talk therapy. Psychedelic assisted psychotherapy is framed as a potential option when standard pharmacotherapies and psychotherapies have failed. So, conventional interventions are medicine um, in the kind of Western way that we know it, and then psychotherapies, talk therapy. Rife and his colleagues are very intentional about the clinical populations they emphasize. These are not mild or transient conditions. They are often treatment resistant, chronic, and associated with profound suffering. For major depressive disorder, the authors highlight populations that have not responded to SSRIs or conventional psychotherapy. Psychedelic assisted psychotherapy is framed as a replacement for standard care. I'm sorry, psychedelic assisted therapy is framed not as a replacement for standard care, but as a potential intervention when existing approaches fail. PTSD, particularly in MDMA assisted psychotherapy, receives special attention. Rife and his colleagues emphasize that PTSD is uniquely resistant to many pharmacological treatments and that MDMA appears to facilitate trauma processing by reducing fear responses while maintaining emotional engagement. So, substance use disorders are discussed in relation to earlier psychedelic research and contemporary psilocybin studies. So, earlier psychedelic research with LSD, current contemporary psychedelic or psilocybin studies. As you know, my experience with cocaine in particular in studying psilocybin. So the authors note that psychedelic experiences may disrupt rigid patterns of craving and self-concept, though they remain cautious about generalizability. So end of life anxiety highlights an entirely different therapeutic goal, not symptom elimination, but existential reconciliation. Psilocybin assisted psychotherapy in this context often targets meaning, acceptance, and spiritual distress rather than diagnosable psychopathology. So, this is a reminder, this slide is a reminder that psychedelic assisted psychotherapy frequently operates at the intersection of psychiatry, existential psychology, and spiritual care. So, MDMA assisted psychotherapy has the most robust evidence base, particularly for PTSD. At least at the time of this article. I'm not sure if psilocybin, it's MDMA is probably still up there. But psilocybin is, if not like tied, a super close second. So there's just like big companies that are doing large, phase 2, phase 3 studies with psilocybin. So the authors emphasize that MDMA appears to enhance therapeutic alliance, emotional engagement, and fear extinction, highlighting the relational nature of therapeutic change. We'll talk about this in a lot of detail when we get to our MDMA weeks in the class. We have 2 weeks dedicated to MDMA, and I'll talk about how it is structurally different, like within the compound, structurally different than psilocybin. It acts on different neurotransmitters in the brain. It's called an empathogen, which like psilocybin is not considered an empathogen, but I promise I will equip you with all of that language. So the authors are very clear that MDMA assisted psychotherapy currently has the strongest empirical support in the field. This is largely due to multiple phase 2 and phase 3 trials demonstrating significant and durable reductions in PTSD symptoms. However, what is most striking and clinically important is how MDMA appears to work. Rather than suppressing symptoms, MDMA seems to increase emotional tolerance, reduce avoidance, and enhance trust. This allows clients to remain engaged with traumatic material without becoming overwhelmed. The emphasis on therapeutic alliance is critical. The authors repeatedly underscore that MDMA's effects unfold within a relational container. The substance does not replace therapy. It appears to amplify the conditions under which therapy become possible. So, for MFT students like you, this slide is essential. It reinforces that psychedelic assisted psychotherapy is not a technical intervention administered to a client, but a relational process co-created with the client. Right, so psilocybin. Psilocybin studies show rapid and often durable reductions in depression and anxiety. So the authors, Rife and his colleagues, note that subjective experiences of meaning, insight, and transcendence often mediate therapeutic outcomes, which complicate purely neurobiological explanations. So psilocybin assisted psychotherapy is, sorry, I don't have anything to drink, is notable for the rapidity or how fast it has its effects. Um, Rife and his colleagues highlight that significant reductions in depression and anxiety often occur after one or two dosing sessions. These are macro doses, and I will differentiate those later in the semester from micro dosing. A pattern that challenges conventional models of gradual symptom improvement. So just think about that. If you have one or two macro doses of a substance or a drug, um, just think about how different that is, like than how we manage um, diagnoses now. You know, it's a daily medication that needs to like take time to build in your system, and that's completely different than psilocybin. So the authors give considerable attention to the mystical type experiences defined by feelings of unity, transcendence of time and space, ineffability, which means like impossible or very difficult to put into words to explain like what your experience was. It's like we don't have words that accurately describe the experience, and profound meaning. So importantly, these experiences are not treated as epiphenomena, so this epiphany, they are statistically associated with better clinical outcomes. This creates a conceptual problem for reductionist psychiatry. How do we study, measure, and ethically work with experiences that resist language and quantification? So, finally, the durability of outcomes raises critical questions. Why do changes persist long after the substance has left the body? Rife and his colleagues suggest that enduring change may be driven by shifts in meaning, self narrative, and values. This is a point that quietly echoes McKenna's insistence that meaning precedes mechanism. All right, so mechanisms of action. That's what we mean by mechanism here is like, why does it work? How does it work? Where does it work? Things like that. So Rife and his colleagues discuss several proposed mechanisms of action, including increased neuroplasticity and disruption of rigid neural networks. However, they acknowledge that neurobiology alone cannot fully account for therapeutic change without considering psychological and relational factors. So Rife and his colleagues carefully review proposed mechanisms without claiming definitive explanations. Neuroplasticity is discussed as increased capacity for new learning, which may allow entrenched patterns of thought and behavior to shift. Default mode network disruption is often cited to explain reductions in rigid self-referential thinking. However, they caution against treating this as a complete explanation, noting that neural changes alone cannot account for the depth of reported psychological transformation. Psychological flexibility is particularly important for clinicians. This construct bridges neuroscience and psychotherapy, describing the ability to tolerate distress, hold multiple perspectives, and engage in values-based action. Psychedelics may enhance flexibility, but therapy determines how that flexibility is integrated into daily life. So, this slide is a good place to remind you that mechanisms do not replace meaning, they coexist with it. All right, so despite promising findings, the authors emphasize caution. Many studies involve small samples, they lack long term follow up, and may be influenced by what's called expectancy effects, which just means like, what did I expect to happen? And now I'm going to like align my life with that, which, may be great. So essentially, kind of like it's similar to a placebo effect. The authors warn against premature clinical implementation outside of controlled research settings. So the authors intentionally temper enthusiasm. Many studies involve not only small but homogeneous samples that limit generalizability. Participants are often highly motivated and carefully screened, which can inflate outcomes. Expectancy effects are especially relevant. Media narratives and participant beliefs may shape experiences and outcomes, complicating the interpretation of results. The authors strongly emphasize the need for rigorous trials, long term follow up, and careful monitoring of adverse effects. So, this slide is meant to model ethical restraint and scientific humility. These are qualities that are essential for responsible clinical practice. Okay, so bringing the two readings together. So together, McKenna and Rife and colleagues offer complementary but tension-filled perspectives. McKenna and Rife are not in opposition. They are speaking from different locations within systems of knowledge and power. McKenna foregrounds ethics, history, and relational ontology. Rife and his colleagues foreground safety, efficacy, and clinical legitimacy. The task of psychedelic assisted psychotherapy is not to collapse these perspectives into one, but to hold them in productive tension. For clinicians, this means resisting both romanticization and reductionism. Ethical practice requires honoring Indigenous knowledge while engaging rigorously with evidence based medicine. So, this course is repeatedly going to ask you to hold these perspectives in dialogue rather than choosing one over the other. Then, just some closing, reflection for you to think about throughout the semester. So I encourage you not to answer these questions immediately, but to carry them forward with you throughout the semester. Who defines healing? Researchers, clinicians, clients, communities, or cultures? Who benefits when psychedelic therapies become legal, regulated, and expensive? And what responsibilities do clinicians hold when working with interventions that can profoundly alter meaning, identity, and worldview? I want to emphasize that psychedelic assisted psychotherapy is not just a clinical innovation, it is an ethical and cultural intervention. How you orient yourselves to these questions will shape not only your practice, but the future of the field. And that is all I have for you.